All right, Chapter 12, Hormones, Exercise, and Training. We're going to look at the major endocrine glands with an outline of human body. Describe how hormones alter cellular reactions, rate of specific target cells. Describe how hormonal, humoral, and neural factors stimulate endocrine glands. List the hormones secreted by the anterior, posterior pituitary glands, how acute and chronic physical activity affects their release. List the thyroid gland hormones, their functions, how acute and chronic physical activity affects their release. List the hormones of the adrenal medulla, adrenal cortex, their functions, and how acute and chronic physical activity affects their release. List the hormones of the pancreas alpha beta cells and their functions, and how acute and chronic physical activity affects their release. Define type 1, type 2 diabetes mellitus, and give 3 differences between these 2 diabetes subdivisions. List 5 risk factors for type 2 diabetes. Outline the benefits of regular physical activity for a type 2 diabetic. Explain the general effects of exercise training on endocrine function. Characterize the functions of opioid peptides, their responses to physical activity, and possible role in exercise high. So the endocrine system, this is endocrine means hormone secreting, okay? And it consists of a host gland, host organ or gland, minute quantities of hormone chemical messengers in a target or receptor organ. So the system integrates and regulates body functions to stabilize internal environments. Endocrine gland hormones affect all aspects of human function. They regulate growth, metabolism, reproduction, heightened acute and chronic response to physical and psychological stress. The hormones maintain internal homeostasis by modulating electrolyte and acid-base balance and adjust energy metabolism to power all forms of human biological work. They operate in synchrony with the nervous system to provide hormonal secretions as needed throughout the body. Nervous system's quick, endocrine system slow. So you have the hypothalamus, pineal gland, posterior pituitary, anterior pituitary, thyroid, parathyroid glands, thymus. All these are locations where these hormones are secreted. You have 3 components. You have the endocrine system, host gland, which secretes the hormones. They lack ducts but discharge substances directly into the extracellular space. You have the hormones themselves, and then you have the target receptor or cell organs. So this is showing right here that you have the hypothalamus, and you have the hormones secreted from endocrine glands travel in the bloodstream to exert influence on body tissues. And you see these hormone molecules that lock and key with the protein receptors in the target cell. Okay, and this isn't just with hormones. This is also with other cellular responses that happen in regards to molecules that lock and key with proteins on the surfaces in the lungs, kidneys, things like that. Hormones, chemical secreted by a cell or a group of cells into the blood for transport, where it exerts its effect at a low concentration. Hormones bind to cell receptors, like we talked about, and initiate biochemical responses, cascade effect, and we'll talk about that. Can be classified by their sources, receptor type, or chemical structure. Peptide hormones, these are range from small peptides of 3 amino acids to large. These are water soluble, so they dissolve easily, transport the body's extracellular fluids. Most bind to surface membrane receptors and act through a secondary messenger. Tissues respond rapidly to peptide hormones compared to response times for other hormones. Steroid hormones. So these are cholesterol derivative. Their chemical structure is a derivative of cholesterol. Only in the adrenal cortex, gonads, placenta construct these steroid hormones. They're hydrophobic, so they are minimally soluble in plasma and other bodily fluids. They bind to protein carriers in the blood, produce an effect on target effect on the target. The hormone actually, so to produce an effect, the hormone has to unbind from the protein. Amines, these are derived from single amino acids, including catecholamines, epinephrine, norepinephrine, which are part of the autonomic nervous system response, okay, which is the sympathetic response that takes place. Okay, how hormones function, they combine with a specific receptor molecule in the cell surface, causing cell to discharge second chemical that initiates cascade of cellular events. This is on page 370. It talks about the extracellular space. You have the hormone that comes along, specific receptor in that phospholipid bilayer of the cell, outside of the cell. You have the adenylate cyclase that takes place that then causes the secondary receptor. You have this cyclic AMP that is generated by ATP to form protein kinase and act to then equal active protein kinase, which targets the active target enzyme, which then addresses the inactive target enzyme, which then addresses the cellular response. So you have the circulating hormones, the first messenger, binding to a specific receptor in the cell plasma membrane, triggering this production of cyclic AMP from the ATP catalyzed. One of the things with this is that caffeine actually stimulates lipolysis, which is the breakdown of lipids, because it augments the cyclic AMP activity in fat cells. It promotes lipolysis and releases fatty acids into the plasma. It stimulates fat oxidation, which in the breath then comes out as you have the carbon dioxide and then water as byproducts of it. But hormones act at specific target cells by one of four mechanisms: by changing the synthesis rate of intercellular proteins, altering enzyme activity, modifying cell membrane, and inducing circulatory activity. Hormones function continued. So a cell's target response to a hormone depends on the presence of a specific protein receptor, so you have to have the receptor for it to attach. Three factors determine the hormone's concentration: the sums of synthesis and release by host gland, the rate of receptor uptake, and the rate of removal from the blood from the liver and kidneys. You have the hormone effects on enzymes, alteration of this enzyme activity, enzyme medium membrane transport constitute major mechanisms of hormone action. So hormones, they affect the enzyme activity, and enzymes are proteins, by the way, that speed up reactions, things like that. So that what do? They stimulate enzyme synthesis combined with enzyme to change its shape through allosteric modulation. So hormones can change the shape, okay? So if it changes the shape of the receptor, protein receptor, target receptor, then it can decrease or increase the enzyme's ability to interact with the substrate, which is the hormone that's in the bloodstream, that's coming to whatever target tissue that is. And this activates many inactive enzymes to form enzyme forms to increase total enzyme activity. Control of hormone secretion, they're stimulated either hormonally, humorally, which is based in the blood, or neural. And what that means is fluctuating blood levels of ions, nutrients, bile stimulate hormone release. Humoral denotes the stimuli to distinguish them from fluid-borne. Okay, increase in the humoral agent, blood glucose stimulates insulin release from the pancreas. Insulin promotes glucose entry to the blood sugar levels decline to terminate the humoral initiative for insulin. So basically, if something is high in the blood, then it stimulates this hormone response, okay, or low in the blood. And then nerve fibers impact hormone release during stress. For example, sympathetic nervous system activates adrenal medulla that initiates the epinephrine, norepinephrine, which either releases in the fight or flight from the adrenaline response, or the norepinephrine, which gives more of a rest or relax type of response. And these neurohormones serve as chemical messengers when neurons release them into the blood. Yeah, it's kind of cool. So you have hormonal stimulation, hormones influence secretions of other hormones, humoral fluctuating blood levels, I talked about that, ions, nutrients that causes stimulation, and then neural, which is nerve fibers affect hormone release. Okay, three major groups of neurohormones. You have catecholamines, which include epinephrine, norepinephrine, hypothalamic neurohormones secreted by the posterior pituitary, which then these end up addressing, if that takes place, they end up addressing the adrenal cortex in a so the pituitary, the posterior pituitary is affected, or the anterior, either one. Okay, so you have the neurohormones control hormone release from the anterior pituitary, and then so hypothalamus is a control based mechanism. It's a control place in the brain that causes, it directs a lot of these hormone release type activities throughout the body. Okay, and it's in response to different things. So you see in your environment, oh my goodness, there's this this amount of weight that I have to lift. So then it stimulates this. In that fashion, the anterior would then, pituitary anterior stimulation from the hypothalamus would then release these neurohormones such as epinephrine, adrenaline, to then lift the corresponding weight. It's an example. Hormone interactions. You have three types of interactions: diverse hormones, synergism. There's two different hormones act together, augment the effect on specific tissues. Permissiveness. One hormone can't exert its full effect without the presence of another hormone. Okay. Then antagonism. One hormone opposes action of another, diminishing the effectiveness of the first hormone. Then you have patterns of hormone release. Most hormones respond to peripheral stimuli as needed basis. Some deal with 24-hour cycle. So that's another way that they are released. Some secretory cycles span several weeks, others follow days. Diurnal patterns, and then patterns of release and or amplitude, frequency provide more meaningful information, hormone dynamics, than the concentration. So this basically says a single hormone, if you measure hormones in a specific spot, that's great, but the pattern, the trend is actually more valid in looking at the information of what is the hormone dynamics, as in over time, how much hormone of something is in your body versus like a specific one-time period. Anterior pituitary hormones. You have growth hormone and anterior pituitary. This facilitates protein synthesis. Oftentimes testosterone too actually then causes the growth hormone to increase. You have stimulation of RNA, activating cellular ribosomes. We know that ribosomes make proteins, so protein synthesis occurs. And then growth hormone secretion increases a few minutes after exercise and relates more closely to peak exercise intensity and exercise duration or total exercise volume, meaning that growth hormone is actually released in activities that are high intensity activities. Okay, that's why the high intensity activities are needed. So for instance, if you're doing weight training and you need to be waiting about 30 to 60 seconds in between sets, and then you should be doing high volume, at least 3 to 4 sets of an activity of a specific exercise to have this high intensity response take place. And so it's pretty interesting. Yeah, high intensity is what this is all about when it's released endogenously. Okay, but it promotes cell division, proliferation. Okay, and this is what this talks about here. Anterior pituitary. So you have the growth hormone that directs actions of, adipose tissue, triacylglycerol release. Okay, so it basically breaks down fats, and also hinders glucose uptake. So it maintains blood sugar levels. So there's feedback controls and things like that actually there's things such as the protein is built. Okay, so there's anabolic effects from the anterior pituitary hormone that releases growth hormone, and then it promotes skeletal growth as well. Some children actually have to take growth hormone because they're deficient in it, and then some people take it too exogenously to try to build mass and things like that. Okay, because it's been known to decrease fat mass and also increase fat-free mass. One study showed that it increased 7% of fat-free mass and decreased fat mass over intervention over the control. Thyrotropin, known as thyroid stimulating hormone, maintains growth and thyroid gland development. Physical activity increases anterior pituitary TSH output. Okay, this thyroid stimulating hormone. Okay. Okay. All right. So it's basically just secretes thyroid hormones. Okay. Corticotrophin, hypothalamus secretes corticotrophin releasing hormones, transport to anterior pituitary, stimulates corticotrophin. Axon adrenal cortex, which releases cortisol. And what this talks about basically is that this ACTH enhances triglycerol mobilization, which is fat breakdown, and then increases rate of gluconeogenesis, which is the building of glycogen, and stimulates protein breakdown. Okay, it's the stress. This corticotrophin is elicits this response of cortisol, and it actually has negative effects as well. So you have gonadotrophic hormones, which is FSH, LH. FSH deals with the growth of the ovaries and secretes estrogen in the females, and FSH in males increases sperm production. Okay, LH stimulates the increase of testosterone, and LH, luteinizing hormone, in women increases estrogen and progesterone. Prolactin governs milk secretion. It's another anterior pituitary hormone. Mammary glands increase levels of higher exercise intensities, return toward baseline, 45 minutes of recovery. Important role in female sexual function, menstrual activity. Posterior pituitary, this deals with oxytocin primarily, which stimulates uterine muscle activity and milk ejection in women and men. There's not much information on that. Posterior pituitary, well, let's go back one. Another thing is it stores antidiuretic hormone or vasopressin and oxytocin. Antidiuretic hormone means that you're not trying to release a diuretic releases water, and antidiuretic keeps water. Okay, so that's one of the things that's important. So physical activity provides a potent stimulus for ADH secretion, which increases water reabsorption from the kidney tubules during and after exercise, because you don't want to lose water when you're sweating and things like that. So that's this ADH secretion actually increases water reabsorption by kidney tubules. It's a beneficial mechanism in the physiological response. Okay, and this just talks about hypothalamus, which, like I said, is the director of things, and then you have the posterior pituitary and anterior, and the majority of the things that we're talking about are coming from the anterior pituitary versus posterior, because the anterior deals with growth hormone, the adrenocorticotrophic hormone, ACTH. We talk about the TSH, the thyroid stimulating. We talk about prolactin, follicle stimulating, FSH, and luteinizing hormone. They all come from the anterior, and then all the posterior just deal with the oxytocin and the antidiuretic hormone. Thyroid hormones has two distinct endocrine cell types. We have the calcitonin, calcium regulating hormone. Then we have thyroxine and triiodothyroxine. TSH, released by anterior pituitary gland, stimulates thyroid gland release hormones. Thyroid gland provides central stimulation for normal growth and development, especially nerve tissue. So you have the parathyroid glands here, and it's like a butterfly. A greater picture for this would be on page 12.5. And it just talks about how it's a butterfly shaped gland, weighs about 15 to 20 grams, located below the larynx, base of the throat. Larger endocrine gland has two distinct types. We talked about calcitonin, we talked about T4, T3. They affect the quality of life because hypersecretion of thyroid hormones or hyperthyroidism increases oxygen uptake and metabolic heat production, increases protein breakdown, muscle weakness, heightens reflex activity and physiological disturbances, increasing irritability, insomnia, and then causes abnormally rapid resting heart rate or tachycardia. Hyposecretion of thyroid hormones or hypothyroidism reduces metabolic rate, decreases protein synthesis, depresses reflex activity, and causes abnormally slow resting heart rate, bradycardia. Um, one thing about don't blame the hormones is that fewer than 3% of people actually have a abnormal thyroid. Okay, in the United States, so about 60% of adults with the fat gain, it's not explained by this thyroid function. It's an interesting side note. Parathyroid hormones, or PTH, raises calcium concentrations 3 ways. And so what does it do? Well, it secretes calcium regulating parathyroid peptide hormone, or PTH, or parathormone, and it decreases plasma calcium concentrations. PTH raises in 3 ways. How does it do that? How does it raise these calcium concentrations? Well, it mobilizes calcium from the bone, which isn't a good thing. Enhances renal calcium reabsorption, kidneys, and then indirectly increases intestinal calcium absorption from influence on vitamin D. So it's good. The thing of it is that when it does these things, there are causes and effects that take place relative to these. Okay, and calcium from bone is okay to a degree, but you don't want to take too much calcium from bone either, because you are then could lead to brittle bone, things like that, osteoporosis. Adrenal hormones. Okay, you have adrenal glands located above on each kidney, are made up of the adrenal medulla, inner portion, and the cortex outer portion. Secrete different types of hormones. We already talked about this. The cortex basically releases. You have the mineralocorticoids, aldosterone, which deals with aldosterone is it regulates the kidney's distal tubules for sodium reabsorption. So basically what it does is it regulates mineral salts, sodium and potassium. With the sodium, conservation of fluid via sodium reabsorption increases plasma volume or blood volume. So it also then increases cardiac output and arterial blood pressure. Okay, so when you have this cortex that is releasing a mineralocorticoid, okay, that's one effect. Another is cortisol, which is a corticosterone. You have the corticosterone in the mineralocorticoid, but then you have the cortisol that's another hormone, another steroid hormone, which cortisol we talked about increases fat and breaks down proteins. Okay, so one of the things in regards to this aldosterone that I want to talk about is that this chronic reduction in renal blood flow based on so if you have a sympathetic response and your adrenal glands are firing, and you have a cortisol increase and an aldosterone increase, what it's shown is in teenagers that it's related to 3 factors in obese teenagers, which is decreased salt sensitivity, increased water retention, increased sodium intake, decreased sensitivity to insulin. So it keeps sodium from passing in the urine, which increases blood pressure. Okay, that's obvious physiological response. So in the medulla, in the middle, what do you have there? We have catecholamines. So when people say your adrenals, my adrenals are fatigued, or my adrenals are, I'm having, this response. Well, it comes from the hypothalamus pituitary axis, which is the hypothalamus, pituitary, and then adrenals, this HPA axis. So if you have this sympathetic response, oh my goodness, I have to do this fight or flight type thing, then your hypothalamus tells your pituitary to then target this, create a response in your adrenal gland, the medulla, that causes this epinephrine or norepinephrine response. Epinephrine is the adrenaline type response, and that increases blood pressure and then increases heart rate and things of that nature. So there's that's the type of thing. That's what this is showing here. Adrenal medulla hormones you have, that's, like I said, sympathetic system prolongs, augments sympathetic neural effects by secreting epinephrine, norepinephrine. Factors increase catecholamine response, exercise intensity, duration, age, gender. secretes adrenocortical hormones in response to ACTH stimulation, pituitary. So you have function of these groups. You either have mineralocorticoids, glucocorticoids, and androgens. And we already talked about this. Adrenal cortex hormones. So what causes, we talk about the hypothalamus, pituitary, adrenal. I said the HPA axis, right? So you have stress, which causes this HPA axis to fire, which causes what? The hypothalamus, stress causes, and circadian rhythm too, sleep rhythm matters, okay? But we'll just go with stress right now. It targets the hypothalamus, okay, which then increases the CRH secretion, which then causes the anterior pituitary. So you have the CRH secretion is a corticotropic releasing hormone, which causes the anterior pituitary to then release the adrenocorticotropic hormone, which then causes the adrenal cortex to increase cortisol. Cortisol does what? Well, cascade of effects. You have the gluconeogenesis, so it's the creation of glucose from the liver. You have the protein breakdown in muscles, decreased protein muscle synthesis, and increase in fat tissue synthesis. Okay, increased glucose it decreases the glucose uptake, and so you have too much glucose sitting there in tissues, and then you have decreasing amino acid uptake. So basically, then you have a negative feedback loop. Okay, once this takes place, then it causes other cascade of effects. So this is what we're talking about when you have this adrenal cortex hormones and you have this response, okay, for this hormonal response. Okay, pancreatic hormones. In the islets Langerhans, you have the beta cells, alpha cells. Beta cells produce insulin, amylin, and glucagon. Okay, and basically this just talks about what happens when in regards to high blood sugar, low blood sugar. You have low blood sugar. You have the isolated Langerhans beta cells. Alpha cells secrete glucagon, which cause glycogen in the liver to create glucose to go into the bloodstream, so that when we have low glucose, okay, so then where our cells are able to uptake glucose and function. If you have high blood sugar, insulin, you have this insulin stimulating glycogen formation to lower blood sugar. Okay, so the pancreas is extremely important in regulating the blood sugar. Okay. Insulin secretion following influence and insulin release after eating. You have increased blood glucose concentrations, increased blood amino acid concentrations, gastrointestinal tract hormones, parasympathetic nervous system stimulation, and sympathetic nervous system stimulation. So what's that mean? You have consumed food, you increase the blood glucose. Okay. So then it activates receptors, digestive tract. You have afferent neurons sending a signal to the brain, okay, from the bloodstream. Central nervous system sends then a signal to the pancreas to lower this blood glucose that's high in the blood, activates insulin, so then that creates the muscle target tissue the insulin goes to then create the glucose uptake and utilization, which lowers blood glucose. So it helps, because blood glucose is not good for high blood glucose is not good for the to be in the bloodstream. Okay, insulin's function. Primary target tissues for insulin include liver, adipose tissue, skeletal muscle. Insulin's major function regulates glucose metabolism, facilitates cellular glucose uptake, all tissues except brain. Insulin exerts an action on glucose following ways. It increases glucose transport, okay, in most but not all insulin-sensitive cells. It enhances cellular utilization, storage of glucose, enhances utilization of amino acids, and promotes fat synthesis. So insulin's a great thing because it increases insulin secretion. What does it do? Increase fatty acid triacylglycerol synthesis in the liver and muscle. It increases glycogen synthesis. In fat tissue, what does it do? It increases fatty acid triacylglycerol synthesis and decreases lipolysis. In most tissues, it increases glucose uptake, okay, except brain, liver, and exercise, increases amino acid uptake, so protein uptake, increases building proteins, and decreases protein breakdown, okay, which is what you want. You want to build proteins and decrease protein breakdown. Glucagon secretion, we talked about this, increases blood glucose levels if there's too low. And what happens is glyconeolysis takes place. It creates, in gluconeogenesis, it creates, in lipid catabolism, fat breakdown, to increase blood glucose from glycogen. Okay, so basically it contributes to blood glucose regulation during exercise and starvation. So in the morning when we wake up, we don't have any. Let's say we're in a ketotic state. What it'll do is, if we haven't had any glucose, sugar, or any type of carbohydrates, it increases fat breakdown, and then it also increases glyconeolysis in the liver, which changes glycogen to glucose to be dumped in the bloodstream, so that we have this energy to be used. Diabetes mellitus, type 1 diabetes, results failure to produce insulin. This talks really about 5 to 10% is type 1. It's when pancreatic cells no longer function effectively to produce insulin. This liability initiated or mediated by the body's immune system severely limits or completely eliminates insulin production and secretion. But it's about 5 to 10% of the population has this type. Type 2 is relative insulin deficiency, results in hyperglycemia. This is about 90-95% of Americans. Gestational diabetes, another one, 4% of all pregnant women. And this is dietary restraint needs to help with this. Sometimes they're given exogenous insulin. This affects Asians, followed by Hispanics, African Americans, and non-Hispanic whites. And then you have prediabetes. The person's blood glucose reaches higher than normal levels, not enough for type 2 diabetes. We'll talk about this. Diabetes signs and symptoms. You have hyperglycemia, which is elevated blood glucose, frequent urination, polyuria, polydipsia, excessive thirst, polyphagia, extreme hunger, high level of blood ketones, from reliance on fat catabolism. So we have, and typically this is above 1.5 millimolar per liter threshold. Others use greater than 10 millimolar per liter to determine whether or not this is too high of ketones. And then we have unexplained weight loss, increased fatigue, being irritable, blurry vision, numbness, tingling extremities, hands, feet, slow healing of wounds, abnormally high infection. Genetics of diabetes, 2 factors, inheritance. Okay, chromosome 6 is approximately 50% of genetic risk for type 1 diabetes. Chromosome 2, about 10%. Okay, most inherent risk factors, both parents, more common in whites. Most prominent environmental triggers: cold, weather exposure, viral infection, and diet. And then genetics of diabetes, family history provide one of the strongest risk factors for disease, but only people living a Western lifestyle. Over fatness provides considerable risk in ethnic groups. Highest risk, type 2, African Americans, Mexican Americans, Pima Indians. And this is also becoming child onset diabetes, actually, because of kids in the way that they're eating in Western diet, things like that. Testing for diabetes. One of the things, too, about the diabetes is that if you're pre-diabetic, it talks about your A1C, hemoglobin A1C test. Well, an A1C test measures the amount of glucose attached to hemoglobin in the red blood cells. And so when it's not looking at blood right now, but it's basically the blood for the last 2 or 3 months. So A1C looks at, so if someone had a higher percentage, like a 5%, 5.7 to 6.4% is in the pre-range for diabetics for the A1C cutoff. And then if you look at above 6.5%, it diagnoses for type 2 diabetes. And this relates to like a 6% in average glucose reading would correspond to about 126 milligrams per deciliter, okay, of this glucose attached to the hemoglobin in red blood cells. The reason it matters is because the longer you're a diabetic, the higher chance you'll develop heart disease. And why is that? Because it's higher A1Cs damage, because having too much glucose in the bloodstream damages blood vessels and nerves that control your heart and blood vessels. What happens through physical activity is it increases insulin sensitivity, which causes that glucose to not reside in the blood, to be uptaken by cells and not damage the the vasculature. Metabolic syndrome represents a multifaceted grouping of coronary artery disease, risk cluster of insulin resistance, hyperinsulinemia characterized syndrome. It's on 387. And it talks about, it looks common characteristics. You have insulin resistance, glucose intolerance, dyslipidemia, or hyperlipidemia, stroke, upper body obesity, type 2 diabetes, hypertension, coronary artery disease, reduced ability to dissolve blood clots. It affects about 25% of Americans. It relates to genetic, hormonal, lifestyle factors, physical inactivity, nutrient excesses, high intakes of saturated trans fats. How do you treat it? Well, long-term management of each risk factor, poor nutrition, reduced physical activity represent underlying causes. So you want a weight loss. You want a weight loss of 5 to 10% of body weight, improves insulin sensitivity, increased physical activity. Increased physical activity reverses insulin resistance. Reduces blood pressure and lowers bad cholesterol, which is like the LDLs, and then it raises good cholesterol, which is your HDLs. It also reduces type 2 diabetes risk. So in eating a heart-healthy diet, so you're reducing saturated fats, so meat, fats, cholesterol, salt intake, and intake. Then you want to increase high fiber fruits, vegetables, and grains. And identifying metabolic syndrome, this is a numerical analysis. You look at the men, if they're greater than 40 inches of waist, women greater than 35, triglycerols or fats in the blood greater than 150 milligram per deciliter. High density lipoprotein, men less than 40 is bad, because you want HDLs, high density lipoproteins. These come from nut fats, almonds, things like that, and even fish. Then you have omega-3 fatty acids, things like that, even omega-6s. And then blood pressure, you want it to be, if you see that it's greater than 130/85, then that's another risk factor. Fasting glucose, 110 milligram per deciliter. Diabetes and exercise, type 1, clinical use of exercise. To control glucose, type 1s, it's complex, although it improves insulin sensitivity, by peripheral tissues. You have to be careful with people with type 1 diabetes, because their glucose drops, and then they can have this shock take place because it's their exercise accelerates this glucose removal from the plasma, which can cause a problem. Then they have diabetic shock, and they have to take like the tabs, sugar tabs, or chew gum or whatever or take their insulin. Their shots. You have type diabetes and exercise. Exercise training provides important non-pharmacological therapy. Type 2, regular physical activity. For type 2 diabetes, it improves glycemic control, cardiovascular function, body composition, psychological profile, and reduces a broad array of heart disease risks, which is obviously you're getting the glucose out of your bloodstream. The glucose is causing the vasculature problems if there's too high of glucose for a long period of time. You have the HDL levels go up, high density lipoproteins. The low density lipoproteins go down. So these are benefits that we see. You basically need less insulin, because you have less insulin resistance. That takes place over time with having type 2 diabetes. Anything else here? No. Endurance training and endocrine function. So a little switch gears here. Endurance training generally decreases magnitude of hormonal response, standardized level. Exercise, particular absolute intensity, produces lower hormonal response of trained subjects with untrained, because basically they've been training. So there's less of a hormonal response. Max exercise, trained subjects, similar or slightly higher catecholamine and pituitary hormone. Hormone response in untrained. So they have, when they're trained, they have a little bit of a higher catecholamine. So you have like the norepinephrine, epinephrine response a little greater than people who are untrained. Endurance training or endocrine function. So endurance training differs affects resting, exercise, hormone on effects on resting and exercise induced hormone production and release. So you have exercise, which elevates hormones response during exercise, which is, so you have cortisol, you do have a cortisol increase in regards to endurance training. It depresses growth hormone. It depresses testosterone. It depresses luteinizing hormone, which causes the testosterone to increase, okay, in the gonads. So endurance training in some ways does depress certain types of hormones, okay? And as we know, testosterone increase, which then leads to GH increase, can increase muscle hypertrophy, size. So it depends on what you're shooting for if you're doing endurance training, although it does help from a cardiovascular standpoint. No known training response occurs with aldosterone and angiotensin. Hormone response to exercise training. I'm not going to go through these, but it just talks about basically you have this hypothalamus pituitary hormone, and some of this depends upon the type of exercise training we're talking about here too. You talk about insulin at the bottom there. Example, training increases sensitivity to insulin. Normal decrease in insulin during exercise is greatly reduced. You have these certain things that take place, such as, but it also pertains to the types of, like I said, activity that you're doing. Resistance training and endocrine function. In general, resistance training increases the frequency and amplitude of test and GH secretion, thereby contributing to hypertrophic effects on muscle. Resistance training in men increases frequency, amplitude of test, and GH secretion. It's not seen in females because females have about 1/10 the testosterone that men have. They have obviously more estrogen and progesterone. They do have some tests, but it's less, so they don't see that response. Another thing too, in regards to resistance training endocrine function, is that GH secretion actually in resistance training was shown, like I said, to increase fat-free mass about 7%, decrease fat mass about 7%, and then there was another study that showed testosterone increased fat-free mass or muscle 14% over the control group. So we know that resistance training affects many things, even endocrine function. Okay. Endorphins, the endocrine system. Endorphins regulate menstruation, modulate GH, ATH, prolactin, catecholamines, cortisol. Exercise-induced elevation of beta endorphins coincides with the euphoria, increased pain tolerance, because it's an endogenous opioid, okay, and the exercise high and menstrual dysfunction. So we know that the endocrine system, there's a lot of psychological benefits from activity, especially endurance training, in regards to this release of this beta endorphin release, which has been seen more prevalent in endurance training types activities. And another thing too is something called BDNF, which is brain-derived neurotrophic factor, that is a molecule, a major candidate, should I say, molecule for exercise-induced brain plasticity, which causes the neurogenesis and things like that to take place, so that some of these neurotransmitters can be released and aid in the effects of this exercise high. It's activity dependent, and there's other things such as these endogenous cannabinoids, such as anandamide, that cross the blood-brain barrier, that actually cause possibly this exercise high as well, or in conjunction with the beta endorphins.